Hi everyone, we're gonna go through our lecture on the physical exam. This is chapter 20 in your book. We're just gonna follow along with the PowerPoint like we have been for our discussions. So our objectives, we're just gonna skip over that. So definition of terms. Differential diagnosis, this is the process of differentiating between two or more conditions that share the same or similar signs and symptoms. So this helps determine what diagnosis is causing the problem or what illness or disease is the problem, and it determines how the physician can treat. So it determines which disease is causing symptoms. This helps so that the final diagnosis can be made. So if someone comes into the office and maybe they have a sore throat, there could be lots of diagnoses that could be causing that sore throat. Do they have strep? A strep infection? Do they maybe have seasonal allergies? Mono can also present with a sore throat. So it just gives, it's a way that we determine which condition is causing that sign or symptom. Clinical diagnosis, this is an intermediate step in determining the final diagnosis. So it's obtained through evaluation of the health history as well as the physical exam. So collecting that information about why the patient is in the office is important, and then the physician examining the patient. So this doesn't include any kind of lab test or diagnostic procedure. It's just the health history. It's the clinical part of it. So what are you doing in the clinic or clinically determine what's wrong with the patient. So you find out what kind of symptoms the patient is having, the doctor does the exam, and then comes up with a clinical diagnosis. The final diagnosis is the scientific method for determining and identifying a patient's condition through evaluation of the health history of the physical exam, and this part includes any lab test or diagnostic procedures. This is just overall often called the diagnosis, or what's causing the problem. It provides a basis for treatment, so how you're going to treat the patient, as well as their prognosis. So maybe that patient that presented with a sore throat, they have a strep test, it comes back positive, so the patient is treated based on their diagnosis of strep throat. They're given an antibiotic, and their prognosis is that they will feel better, usually within 48 hours. Prognosis. This is the probable course and outcome of a patient's condition. And then the patient's prospects for recovery, or their estimated recovery. So this prognosis, nothing should ever be promised that they're going to be cured. Medicine is very unpredictable, and so all patients are also very different. So it's important you can give the likelihood of an outcome and set realistic expectations for the patient. This isn't your responsibility, but it is the provider's responsibility to kind of give them some expectations of how they should be feeling and when, and some outcomes they should expect. Risk factors. That's a physical or behavioral condition that increases the probability that an individual will develop a particular condition. So this has to do with the fact that your chances are greater of developing a type of medical condition. So genetic factors. Some diseases have a genetic component. Maybe a patient's mother has breast cancer. That makes her more high risk for developing breast cancer in a younger patient. Habits like smoking can contribute to that chronic obstructive pulmonary disease or COPD. It can also contribute to lung cancer. Any kind of environmental conditions, so surroundings that the patient is exposed to that increase their likelihood. Maybe they have a parent who's an alcoholic. That might increase their risk of being an alcoholic themselves. Physiological conditions, that might be someone with obesity. So with obesity, that can increase their risk of diabetes. It can increase their risk of heart disease. So just different factors that can all contribute to someone being more likely to develop a specific medical condition or disease. We'll continue to talk about these definition of terms. These definition of terms are going to be important for you to know. They're important for your quiz. Acute illness. This is something, it's an illness that's characterized by symptoms that come on very quickly and suddenly, usually is severe and intense, and it subsides after a short time. So we talked about that strep throat. There's some examples there. Strep throat. A patient comes in, they have a sore throat. It happens very quickly. It's happened over the last day or two. They quickly feel poorly, and then it gets better after they've started their treatment within a short period of time, usually days. Sometimes an acute illness can last weeks or months, but often we think of acute illness as being like a virus, like a virus or infection, maybe an injury, maybe something that's caused by misuse of medication. And a chronic illness, that's symptoms that persist for more than 3 months. So patient shows little change over a long time. So a chronic illness, hypertension is a very good example of a chronic illness. Emphysema and diabetes, those are both chronic. Those symptoms develop slowly. Maybe someone who has been having, someone with hypertension, maybe they've been having headaches off and on for a short period of time. Maybe they slowly become more intense and more frequent, and they go to the doctor and their blood pressure is high. That might be something that develops slowly and then worsens over an extended period of time. A lot of times, chronic illnesses can be caused by unhealthy behavior that increase our risk, maybe poor diet, sedentary lifestyle, not very active, smoking, overuse of alcohol, and chronic illnesses can develop as people age as well. Laboratory testing, that is testing that analyzes and studies specific specimens that are collected from the patient to help diagnose and treat a disease. Maybe someone, that patient with a strep infection, they had a strep test. Maybe someone with, let me move this out of the way. Maybe someone who comes in with some urinary symptoms. They are having burning when they urinate. They're having some low belly pain, some low back pain, and they do a urinalysis that shows a urinary tract infection. A hemoglobin test, that patient who has a low hemoglobin level. And then to go along with that, a diagnostic procedure. A test that's more of like a colonoscopy, a mammogram, a chest x-ray, a diagnostic procedure. It's a procedure that helps you diagnose a condition. So maybe that person that comes in with a cough or shortness of breath, the doctor sends them for a chest x-ray and diagnoses them with pneumonia. A therapeutic procedure is used to treat a patient's condition with a goal of eliminating that condition or promoting as much recovery as possible. So maybe they get a medication. So that patient who comes in with a positive strep test, they're giving a medication as their therapeutic procedure. Maybe someone gets ear irrigation. Radiation therapy is often therapeutic. For cancer, it often eases pain or shrinks their tumor. Components of the physical exam. So there's 3: health history, physical exam, and then laboratory and diagnostic tests. So a health history is very important. That gives the background and paints a picture of why the patient is in the office and helps direct the doctor on areas to focus during the exam. And then it'll give some indication of what laboratory and or diagnostic tests to order. The physical exam is a complete a full body exam if they're in for a checkup. If it's acute, someone's being seen for an acute illness, it might just focus on specific areas of the body. If they come in for that strep infection, the doctor may just look at the ear, nose, and throat. As compared to someone who's diabetic, the doctor is going to want to make sure that their heart is okay, that their lungs are okay, they're not having any abdominal problems or pain, and also check their feet to make sure there's no open wounds or sores. So that physical exam can vary a little bit depending on the patient and their symptoms. The laboratory tests, again, and diagnostic tests, those depend on symptoms. So do they need blood work? Do they need an x-ray? Do they need another type of test to help figure out what's going on? So introduction to that physical exam. That introduction is used to detect early signs and symptoms of illness. Sometimes patients will come in to get a physical for their job. Kids, we know they need school physicals, they need sports physicals, they need camp physicals. Again, someone's in for an acute illness, or they're being seen just as a routine checkup for their chronic medical conditions. So those results during the physical exam, that helps the doctor determine the patient's state of health, give them a diagnosis and treatment, and then observe any changes in the illness after treatment has been started. So maybe if a patient doesn't improve, the doctor might need to evaluate the patient and determine if additional medications needed, maybe additional treatment, maybe that patient with the sore throat, the antibiotic didn't work, or the strep infection came back. Maybe that patient now needs a referral to a specialist. Someone who comes in and they're treated for high blood pressure or hypertension, maybe they're started on a medication and their blood pressure improves, but it's still too high and the doctor wants to give them some more medication. So that might be a way that they observe changes in the patient's symptoms after the treatment's been started. So preparing the patient for the exam. It's helpful to provide the patient with a comfortable and healthy environment. It helps them to be more cooperative and more comfortable during their exam. It helps to be honest with the patient, or helps the patient to be honest with you, rather, and just having that non-judgmental attitude towards the patient is so helpful in helping them feel comfortable. So when you talk about a room, it's helpful if the room can be free from clutter and well lit. It's helpful if it's well ventilated. It's a comfortable temperature. Of course, we know when we go to the doctor that it's always cold, or you go in for a surgery, it's always cold. A lot of medical assistants and staff in the doctor's office will check daily, check the exam rooms daily to make sure they're stocked and that everything the doctor will need or that you will need is in that room. Usually emptying waste receptacles and biohazard containers. The biohazard containers is more your responsibility, but usually the trash is emptied by housekeeping when they're there. But it may be your responsibility. Again, cleaning and disinfecting the exam rooms, the tables, the countertops, the faucets, all that equipment that's in the room. Maybe you're wiping down blood pressure cuffs, whatever might need to happen. There's no dust or dirt. There's towels. You have towels to dry your hands. A lot of doctors' offices have table paper on the tables that needs to be changed after each patient is seen, gowns and drapes, and then again, making sure the patient's privacy is ensured. That's huge. That's a big part of our job, is patient safety and maintaining their privacy. So it may be your responsibility to clean and prepare the items the doctor will be using during exams. That's a lot of your responsibility, actually. Making sure that instruments are working, making sure that light bulbs are replaced. Maybe there's a specific light the doctor likes to use, and maybe that light has a burnt bulb, so making sure that everything works correctly, and that maybe supplies are laid out if you know that you have someone coming in for a suture removal. Maybe you have that equipment in the room already, and that it's important for you to know how to operate and care for the equipment too. So maybe how to change the table paper when it's out, replace those batteries that need replacing, and where to find equipment and things that you need for your day-to-day routine. The doctor might use like tongue depressors, alcohol wipes, all those things that you see in an office. Also, making sure that you're keeping the door closed for the patient or curtains pulled. Most rooms are designed that when you open the door, you're not going to see the patient sitting in the room, but that's not always the case. Also, when you're preparing the examining room on page 409 and 408, on page 408, table 20-1, I believe there's a sample. One of these is a sample of some equipment you might find. And then on page 409, figure 20-1, it might be helpful for you to review those as well. So preparing your patient. So that's your responsibility in the doctor's office to prepare the patient for the exam. You're going to, of course, greet the patient in the waiting room and take them back to the exam room. The big patient identifiers, this is going to be important for you to know, is name and date of birth. That's how you identify your patient. You might have to also compare information with demographic data, like their address, maybe the last four of their social, maybe the provider that they're seeing. There are those patients with the same name and same date of birth that are out there. You want to make sure certainly that you have the right patient and taking them back to the room. It's important that you ask the patient their date of birth so that you're not violating HIPAA. If you ask them, is your birthday 11/7/79, then that's a breach of HIPAA information. So it's important that they give you that information. Again, as you're preparing the patient for their exam, you're going to take their vital signs, measure their height and weight. I know a lot of times when you're called back in the doctor's office, a lot of what we do is you greet the patient, you go to the waiting room, you call their name, you greet them and we bring them to the scale and get their height and their weight, usually a weight on every visit. A height for us is once a year, and I know that's typically recommended. A lot of times that'll just first be collected, maybe at their initial visit. You might be explaining what they're there for or what's going to happen while they're there, answer questions to help make them feel more comfortable. Maybe if they have a preferred name or these days a preferred pronoun, that's helpful for them. Just being very friendly and supportive with a helpful attitude helps them feel more comfortable, especially if you're speaking clearly, and just verifying that they don't have any questions. Asking the patient if they need to use the bathroom. 1, you might need to collect a urine specimen. 2, it just helps if they maybe have a weight. A full bladder can affect a lot of things, especially if they need to disrobe. But you may need to give them specific instructions for disrobing. Does the what clothing to remove? Are you giving them a paper gown, a fabric gown? Does the gown need to open in the front or the back? Give them some instructions on how to put that on or what they're going to be doing. You might need to assist someone who's elderly and needs a little bit of help getting their clothes off and getting the robe on or gown, whatever they're putting on. And you want to make sure that it's private and there's places for them to put their clothes. They know where to sit. They can sit on the exam table. Maybe they can sit in the chair. There might be hooks or hangers on the back of the door or maybe on the wall. So just knowing that and giving them that information helps them feel more comfortable. It's helpful if you can review their medical record before they're in the room, so that you know what's going on with the patient, what they're being seen for, things. That way you can anticipate what is going to need to be done. There's a designated location, and make sure that you are following HIPAA privacy rules. So if you have the medical record in the room, that the patient can only see their record and not maybe the daily schedule for the physician. Again, helping the patient on and off the exam table for safety. Maintaining that privacy is just a very important part of our process. And having that, a lot of times everything's on the computer now, so everybody can be in the patient's chart at the same time. You may not be able to be in the same spot, but just that everybody has access now to that record. Measuration, that's the process of measuring the patient's height or their height and weight. A change in weight might be significant. It can help form a diagnosis of a condition. It can be helpful in prescribing treatment. Patients can refuse their weight, and it's important to document that if they do. But the doctors can give additional support if it's needed. There are some guidelines regarding height and weight on page 413 through 414 in your book. There's procedure 20-1 as well on page 415 to 417. Underweight or overweight patients who are on a diet therapy program. So those are patients you really want to make sure that you're taking their weight regularly to determine their progress. Prenatal patients, or prenatal means pregnant. So those patients who are pregnant, it's important to weigh them at every visit. And the big reason for that is to assess the fetal development. You are also looking at mother's health, but the fetal development is the important part. They might have weight loss because of nausea or vomiting, but you want to see that weight go up so that you know the baby's growing. That's one way they can help to do that. Weight, again, measured at each office visit. The patient can refuse, and usually height's only measured that one time at the first office visit, and then we do one yearly where I work. So maybe they want that at specific visits, usually during physicals, depending on the age, but they don't have to be done with every visit. Children, those are the ones that we want to weigh and measure at each office visit. Sorry, my battery's going low. Okay. Children, weighing and measuring them at each office visit. You're observing their pattern of growth. All pediatric patients, their weight and height is plotted on a growth chart, so the doctors can see their pattern of growth. And when children are smaller, we use height and weight a lot to calculate and determine dosage of medication. So it's very important because you want to make sure you're giving that child the right dose of medication. You don't want to over or underdose them. So height and weight are used for the following reasons. We determine body mass index. That correlates with the total body fat content, and it indicates a risk of developing chronic health conditions due to obesity. So the higher your BMI, BMI is used to diagnose obesity or classify obesity, maybe is a better way to say that. It's compared against a standardized chart, and it's to help to determine if a patient falls within the normal BMI index compared to the norm. So when we talk about measuring weight and height and calculating that BMI, there's a website where you can calculate it. There's also some steps to follow. So I'm going to give you this example because this is a little bit hard to understand. So if a patient weighs 135 pounds, you would multiply that 135 by 703. So when you multiply 135 by 703, you get 94,905. If their height is 66 inches, then what you would do is divide that 94,905, you divide that by the 66, and you get 1,438. You again divide that by height, that number. So that 1,438, you're going to divide that by 66. Your answer to that is 21.79, which gives a person a BMI of 22, which is normal. But that's how it's calculated. Typically, in our computer system, everything is done for you. So if you put in a patient's height and weight, it's going to give you their BMI. So if we talk about how to measure weight, it's helpful for it to be in a private area. It's not always. What you want to make sure you're not doing is saying the patient's weight or their height out loud. If they want to know what it is, you can certainly tell them, but I try not to shout that out. There's a lot of scales. Some are digital, some have to be balanced, so you want to make sure that you balance the scale. It's really important that wherever you work, you look at the scale so that you know what the measurements are. Is it in 2-ounce increments? Is it in half-ounce increments? But you want to make sure that when you are weighing a patient, that the scales, there's weights on the scale whenever it has to be balanced. That's on a balance scale. So if it doesn't balance, the weight isn't accurate. You want to make sure that you're recording it correctly. So again, you want to assist the patient. You want to make sure the weight you take is accurate, and you do that by interpreting those calibration markings accurately so that you get the correct weight. We measure a lot in pounds, but sometimes scales measure in kilograms. So it's important to know that 1 kilogram is equal to 2.2 pounds. So if a patient weighs 200 pounds, you would divide that 200 by 2.2, and you get 90 kilograms. A lot of times that's used in kids to calculate their medication and what they're getting, but you might be asked to do that. So it's important to know 1 kilogram is equal to 2.2 pounds. You take whatever they weigh in pounds, divide it by the 2.2, and you get their weight in kilograms. So when you use an upright balance scale, again, you want to make sure that it's safe. A lot of times if they're on a balance scale and there's that platform, that scale can be wobbly. So you want to make sure that you assist the patient to step on that platform when you're using the upright balance or the upright height measurement. You also want to make sure that when you're weighing and getting the patient's height that you have them remove their shoes, that you've asked them to remove their coats, maybe a sweater or jacket. so that you're accurately getting, you're accurately getting their weight, but also there's no obstruction or things in the way when you're getting their height as well. So again, providing the patient safety, making sure that their back is to the calibration markings. And the reason for that is when you use an upright balance scale, the part that comes out to measure their height, that can hit them in the face, that calibration rod. So you want to make sure if it's not stationary, some of them flip up and down, it might hit them in the face. Again, you want to make sure that before you get someone's height, you've looked at what you're using to measure their height. Is it in inches? Is it in centimeters? Do you need to convert it to inches if it's measured in feet? You want to make sure that you are measuring them correctly and that you're recording it correctly. You want to read that measurement correctly to the nearest quarter inch. So you read the measurement where that stationary calibration rod and whatever is movable at that junction, so where those meet. If that makes sense. It's hard to explain when you can't see it. But hopefully we can do that in the lab when we're back. If the patient's height is less than that top value, you want to read the measurement directly on the stationary rod. So wherever they hit, you want to make sure that you're reading that. A lot of them will have an arrow directing you to where that measurement is. Again, if you are recording the height measurement, you want to make sure you're recording it correctly. You might need to record it in feet and inches, or just in inches, but if you're calculating the measurement of 60 inches, you would want to convert that. You can divide it by 60. Divide 60 by 12, and then you get 5 feet. Okay, let's talk about body mechanics. So body mechanics are important because it avoids skeletal muscle injury. It helps to use correct muscles and maintain proper balance and posture and correct body alignment. So daily activities in the medical office carry risk of developing acute or chronic musculoskeletal injuries. So it's important to use proper body mechanics when you're standing, walking, sitting, lifting, positioning a patient, or transferring a patient. It's very important. It should be used anytime the medical assistant is helping patients in and out of a wheelchair, on and off an exam table, assisting with procedures, or moving equipment. So proper use of body mechanics prevents musculoskeletal strain. That's important to know. The back is the most common area of injury, and it can occur with with moving patients around. And it can also occur in the knees, neck, shoulder, and wrists, but the back is certainly the most common. Body mechanics help you conserve energy. They protect your body from injury. They help you to keep your body control and balance, and it promotes effective, efficient, and safe movements of your patients. Back injury prevention. So the goal when you are using body mechanics is to maintain the natural curve of the vertebral column in proper alignment. So you want to keep your back aligned when with using good body mechanics. Your vertebral column, if you remember, it has 4 curvatures, and those are the cervical, thoracic, lumbar, and sacral. And your vertebral column extends from your skull to your pelvis and consists of your vertebrae. So the vertebrae have those shock absorbing discs that allow you to bend and twist. But those discs can deteriorate over time. Remember, we talked about that as aging in the skeletal system. They can narrow and harden. They can even crack and tear. But as we get older, and even with any kind of degenerative disc disease, the discs lose that shocking ability, and you can develop pain and stiffness in that area of deterioration. The disc, those themselves can bulge out from between the vertebrae, so that shock-absorbing disc can come between the bones or the vertebrae in the back, and they can also rupture. Very painful. So when you're using good body mechanics, your movements should be smooth and coordinated. Your body should be in a good physical condition, and you should not reach for something that is more than 14 to 18 inches away. Working at a comfortable height, if it's possible, you should push, pull, or slide an object rather than lift it. Let's go back a little bit. So we talked about the cervical. The cervical is your neck. The thoracic is your upper back. So we think about our thoracic cavity. Our thoracic vertebrae are in that area. Your lumbar, that's more your lower back, and the sacral is the bottom of your back, almost at your tailbone there. Things I'm forgetting to tell you. We talked about these discs that can deteriorate over time. That can really happen with repeated bending and twisting that you do improperly. So that's why it's important to talk about this. A lot of times the disc disease or the herniated disc, those are treated with physical therapy, medications like muscle relaxers or anti-inflammatory medications, sometimes even surgery. So it puts you out of work, which is not good. So let's go back to working at a comfortable height. So you want to make sure that you're not bending at the neck or putting your back forward. Always work between the comfortable height is between your waist and your elbow. And you want to always make sure that you're moving, if you are moving maybe a procedure table, if someone's going to have a procedure in the office, you want to make sure you're moving that table up to a good working height. If you're pushing, pulling, or sliding an object rather than lifting it, that's going to help conserve energy and put less stress on your back. And of course, storing those lighter items on higher shelves and cabinets, and then the heavier items below or at your waist level. And that's just, again, you're keeping that strain off of your back. Again, to continue to use proper body mechanics, you want to avoid reaching. So from an overhead shelf or cabinet, you don't want to reach and grab something that's heavy. You want to make sure you're using a step stool that's appropriate for your office to use. When you're lifting an object or transferring a patient, you want to use those large muscles of your arms and legs. You want to avoid using your back. And then when transferring patient, you want to encourage that patient to help you as much as possible. So encourage them to stand up with your help, just so that it's less strain on your back. So some other important components of proper body mechanics. These are important because if a patient would be in the office, they become dizzy or start to fall. You don't want to try and hold that patient in an upright position. You want to try to balance yourself with your legs apart so that you can help that patient gradually lower to the chair or the floor. And always it's important to ask for assistance. If you don't think you can do something by yourself, you want to ask for help from a coworker. But keeping your legs apart just gives you a wide base of support to help. Again, good posture, you're reducing strain on your back by keeping that vertebral column in a natural alignment. Shoes, comfortable shoes are helpful because you're on your feet all day. You want to make sure you're holding your head up and keeping your back straight, your pelvis tucked inward, and your chest forward. Your posture just provides good balance and stability for you. Just keeps, again, your vertebral column in that natural alignment. And there is a picture in your book on page 420. It's figure 29 that gives you an example of this. Sitting. When you're sitting in a chair, you want to make sure it has a firm back and that your back and buttocks are supported by that chair. A small pillow or a rolled towel on the lower part of your back can provide some lumbar support, which sometimes helps. Making sure your feet are supported by having them flat on the floor. Sometimes using a footstool can help if you're sitting for long periods of time, and taking stretch breaks is important. So again, as we talk about lifting, so if you can, to determine the weight of an object, to see if you can safely lift it, it might be helpful for you to try and push the object with one of your feet to see if you can do that easily. If you can't, then you would want to get some help, or see what your office policy is as far as using that. Again, a wide base of support. You want to make sure that you're standing in front of the object and that you're balancing your feet. Balance yourself with your feet 6 to 8 inches apart. Your toes are pointed outward, and you want to make sure, again, that you're using those leg muscles to lift, bending at the knees and hips, not bending over to lift something. Never bend at the waist. And on that last slide, again, there's another picture on page 420. It's figure 29 that shows you an example of that. So as you go to lift that object, you want to make sure that you're using both hands, that you keep your back straight, and that, again, you're lifting with your legs. Your back muscles aren't as strong as your leg muscles. So that's why it's important to use your legs. You want to keep that object as close to your body as possible and at waist level. And never lift higher than your chest. Pivot, making sure that you pivot your entire body, not twisting, because that can cause injury. You want to make sure that you've checked your surroundings too before you're moving an object around to make sure there's no tripping hazards. And then bending from your knees to lower the object slowly, and again, letting your leg muscles do the work. So as we move on to positioning and draping a patient, I'll just have to move that around. Correct positioning of your patient facilitates the exam for the physician. What position you put that patient in depends on the exam or procedure that you're going to do, and it's important that you know those positions to put the patient in for which type of exam or treatment. It allows for better visualization of whatever exam is being done, and that draping is important. That's important. Because it provides warmth and modesty for the patient. So whenever you are positioning a patient or draping them, you want to make sure that you're explaining to them what's being done and what kind of position they're going to be in. Maybe you need to assist them into that position. Again, using your proper body mechanics to make sure that you're not hurting yourself or bending over or twisting. You want to make sure that you've considered the endurance and the degree of their wellness. Are they elderly and ill? And just be very mindful of those uncomfortable positions. You might need to allow them to rest before they're moving around or switching positions. Again, draping the patient, that just provides modesty and comfort and warmth for them. Again, we talked about gowns and drapes. They can be paper or cloth. And it's important, that you're maintaining their dignity and giving them a level of comfort. So sitting, of course, you might be sitting on the exam table. That might be a position that the patient's in when the doctor's going to examine the head, neck, chest, or upper extremities. That's the position the patient is in when you are measuring vital signs. Supine, that's laying down. So when you're in a supine position, you're laying down flat on your back with your face up. A picture of that is on page 422. It's procedure 20-3. When you're putting a patient in this position, the physician might be examining the head, the head, chest, abdomen, or extremities. Sometimes it's difficult in those patients with a respiratory illness if they're not breathing well or if they have back pain. It might be difficult for them to be in that position. You also want to make sure that a lot of the exam tables have a extension that you can pull out to help support their legs to help keep them more comfortable. And then a prone position, that's when the doctor is going to examine the back or maybe assess the extension of the hip joint. There's a picture of that on page 423, procedure 20-4. That is a position where you're going to put the patient laying face down. You want to make sure that you help them so that they're not at the edge of the exam table. And of course, this position can't be used in pregnancy. The dorsal recumbent position. This position is used for a lot of vaginal and rectal exams. If a patient's going to have a urinary catheter inserted, maybe those patients who have trouble maintaining that supine position. This example is on page 424 in your book, but the patient's on their back with their lower extremities flexed and rotated outward. It's important to drape that patient, of course. The lithotomy position, that's the same as the dorsal recumbent, except patient's feet are in stirrups. That's the only difference there. You want to make sure that their bottom is at the edge of the exam table during that positioning to help facilitate an exam with a speculum. That procedure or that position is on page 425 to 426. It's figure 20-6. A Sims exam. This can be used if you're going to get a rectal temperature, if someone is going to have some type of scope or enema in the office. The patient lies on their left side with their right knee and hip bent. Again, this one is on page 427. Knee to chest, that's when the patient's if the physician needs a better exam during a rectal exam, so the patient lies prone, again, that's with their face down, but their knees are bent up to their chest. There's a picture of this on page 428 that you can see. It's procedure 20-8. And then Fowler, that's a position for patients with exams of the upper body with cardiovascular and respiratory problems. So someone who has that emphysema or COPD, maybe they have congestive heart failure, they're in a semi-upright position. So their knees might be bent, they might be straight, but they're in just elevated like at a 45 or a 90 degree angle just to help them breathe easily. So next we're going to talk about wheelchairs. All seen a wheelchair before, but there's some different types. There's transport wheelchairs, there's standard manual, mechanical, pediatric, and sport. And so patients usually who have their own wheelchair, they might be able to transfer themselves to the exam table or to the chairs. Other people require assistance. It just depends. Maybe you have an elderly patient who's in the office who's feeling more weak. You might have to help them as opposed to someone who's used to using that on a daily basis. The OSHA recommendation is that assistive devices should be used to transfer patients, so we're going to talk about that. Let's go back though and look at this, the types of wheelchairs. So the transport wheelchair, that's a wheelchair that has all four wheels are small, and it's made for just for transport. So usually someone is pushing that patient in a transport wheelchair. It's usually smaller and it's lighter weight. That way it can be put in and out of the car easily. It's not very heavy. The standard manual wheelchair, that's what you see a lot in the hospitals or offices. It's where the front wheels are small, the back wheels are large, and the patient can self-propel them if they have enough upper body strength to do that. Mechanical wheelchair, those are ones that are motor operated. So some patients aren't strong enough to propel their own wheelchair and they don't have any assistance, so they might need some type of power chair or power scooter. A pediatric wheelchair usually has a smaller frame and a shallow seat. And then a sport wheelchair, you might see those a lot with basketball players who play the wheelchair events. A transfer belt. So a transfer belt is also known as a gait belt. Some of those assistive devices, we're going to talk about that, but a transfer board or a gait belt or a slide board might be used. But let's talk about this gait belt first. So this is a safety device that we use to help transfer patients. It's about 1 to 2 inches wide and 48 to 60 inches long. There is a picture of one on page 429. It's figure 20-10. A lot of them are made with canvas, and you wrap that around the patient's waist. You put it on snugly so that you can help the patient stand to transfer, and it's just safer for you to use and safer for them. You're not pulling on them and they're not pulling on you. Again, it's wrapped around the patient's waist over their clothing. You want to make sure that it has a snug fit and it provides that secure grip to hold on to the patient. And you can help them control their movements. It makes it more comfortable. It makes them feel more safe. It gives them some reassurance and security. And again, it reduces your chances of being injured. You don't want to grab onto a patient underneath their arms to help them stand. The transfer belt is a much safer option. So as we talk about wheelchair transfers, it may not always be possible to transfer a patient when they're in a wheelchair if they're too weak to do so and it's not safe. You want to make sure that you are assessing your own ability to make that transfer. You don't want to cause any undue harm to yourself. So you want to make sure that you ask assistance and that maybe if that patient isn't able to get onto the exam table that you're letting the doctor know. They might not need the patient on the exam table. But if they do, there might be a specific room with a certain table that raises and lowers an exam table that the patient may be able to get onto more easily so that the doctor can assess the patient properly. One way that I've always found that you can see if the patient is able to stand on their own is if they're in a sitting position, can they raise their feet off the floor? So can they lift their knees up and raise their feet? So the extent of the assessment during the physical exam, that really depends on the purpose of the exam and the patient's condition that they're in. A complete exam is a thorough assessment of all systems. So the doctor usually starts with the head and goes all the way down to the feet. Really doesn't require a lot of changes by the patient or position changes. And the doctor will use kind of an organized and systemic approach on how he evaluates the patient. We use this most typically during an annual exam or a checkup. Maybe a sports physical or a work physical is when the complete physical exam is done. But the doctor will usually examine. They might examine hair, skin, or nails. They might look at the face and check for symmetry, check their vision, their ears, maybe their mouth and teeth. Might check the neck and see if they have any lymph nodes that are present. See how well they're able to move. Listen to their heart, their lungs, their abdomen, and their legs and feet. So documentation on a patient, there's the paper-based patient record where the doctor notes the results. They might have pre-printed forms. You might see that a lot with history and physical form on someone who's going to have surgery. And then the doctor will use that maybe to later dictate the findings, or maybe the surgeon wants a copy of that information sent to them or faxed to whatever hospital they're going to have their surgery at. We see that commonly. Otherwise, electronic medical record, I think that's pretty standard now, where everyone records any findings in a computer. You can use free text. You can just type in what you want to say. There's drop-down lists. There's check boxes. A lot of physicians will use a program called Dragon that will just dictate for them. But a lot of times, reports are generated from having that electronic medical record and can generate a report on that physical exam to be sent wherever it needs to go. So different types of techniques. We're going to talk about inspection, palpation, percussion, and auscultation. So inspection. That's the process of observing a patient to detect signs of disease. So that's an assessment technique that is used often. You want to make sure that your lighting's good and that you're watching your patient. So what are they saying? What kind of facial expressions are they making? It's important to look at your patient. You can learn a lot just by maybe the color of their skin, expressions on their face. So paying attention is important. When you're looking at the skin, again, the color of their skin, maybe how they're speaking. Do they have any rashes or scars? Are things symmetrical? Are you noticing that their face is drooping? Are they aware of their surroundings? Maybe what's going on? Do they have control of their body movements? Maybe they're having weakness on one side or the other. Inspection can kind of give you a feeling if they're anxious as well. When we talk about palpation, that's of course feeling with our hands to detect a disease. So we talked about whenever the physician is performing a physical exam, he's checking lymph nodes. He would do that in the neck by palpating around the collarbone. You can do it along the neck, behind the ear, and can help feel different areas. Maybe if he's palpating the abdomen, it's looking for pain or any kind of facial expression, indicating that the patient is in pain. It can help with placement and size of organs, presence of lumps. So again, checking those lymph nodes. We talked about the spleen and how sometimes in really significant infections, the spleen can be enlarged. So that might be a time when the doctor is using palpation to get placement and size of organs. Again, evaluating pain or swelling, maybe tenderness in an area or the temperature of a specific area. Is the skin warm to touch? Any redness that's there? Swelling maybe of the joints. Light palpation is used to feel those abnormalities that are on the surface. Use fingers to press down 1 to 2 centimeters. Light palpation is used when you're checking a pulse. It can be used again in those lymph nodes. If you're using deep palpation, again, that's maybe where they're checking the spleen because they got to kind of go up under the rib a little bit. The patient has to take a breath in, so it's harder to feel. So that might be a time you'd use deep palpation. Again, with light, maybe you might be feeling if the skin is moist as well or damp. Are they clammy? Another example of deep palpation would be during a pelvic exam when a physician is checking the ovaries and uterus on a female patient. She might see if she can feel those ovaries. Sometimes that's not a good sign. So that would be another example of deep palpation. Percussion, this is the process of tapping on the body and listening to sounds that can help determine signs of disease. So again, size, density, and location of organs. Any condition that changes the density of an organ or tissue, such as fluid, will change the quality of the sound. I have always seen this used on the bladder to see if the bladder is full of urine. So that's a common thing that I've seen. Technique, this is where the fingertips are used to produce a sound vibration. So the non-dominant hand, so for me, it would be my left hand is placed over an area with fingers slightly separated, and then you strike the joint of your middle finger. You can see where I'm tapping, and it produces a sound vibration. Again, helping determine fluid is what I commonly see, or placement of a location of an organ. Dense structures produce a dull sound, like the liver and spleen. Any empty or air-filled structure, like the lung, will produce a hollow sound. And any condition that changes density of an organ, like fluid, will change the quality of that sound. Auscultation, that's when we listen with a stethoscope. Again, to detect signs of disease. So we listen to the heart, lungs, the belly. We measure blood pressure with that. Going back to percussion, there is a picture of that technique that's described. It's on page 435, figure 20-12. So auscultation, some guidelines. Some things that you want to do. You want to make sure that you've minimized environmental noise, so especially when you're checking a blood pressure and encouraging a patient not to talk because it interferes with their listening. The diaphragm, or a chest piece, that's used for high-pitched sounds. When you look at a stethoscope, that's the larger part of the chest piece. The bell is the smaller part, and it's used for low-pitched sounds. And it's important to clean that chest piece with antiseptic, so an alcohol wipe, and try and warm it before placing it on your patient. Or warn them that it's cold. So when you are assisting the physician, it's your responsibility really to be there for the patient and to help them with any position changes that they might need, getting instruments and supplies, a lot of reassuring the patient, reducing apprehension, assisting the patient off the exam table. Sometimes you aren't even in the room, but maybe with an elderly patient, the physician might need some assistance with that exam. So it just kind of depends what's going on with who the patient is, what their needs are, lots of different factors. Providing patient with additional information. So do they need to schedule a follow-up visit? Maybe helping them with that. Patient education and promoting wellness. So maybe you are changing a bandage. Maybe the doctor has done a procedure and you're bandaging that area and you want to tell the patient how they care for it when they get home. There's going to be specifics that the doctor is going to want you to give them. And then instructions if they've had a lesion removed. When do they contact the office? What signs and symptoms are they watching for? Usually they're going to want to watch for signs of infection. So fever, warmth, increased pain, swelling, redness, drainage that has a color or is foul smelling. Those would be some things. Maybe you are instructing them on maybe a procedure, like a preventative procedure, like a mammogram on a woman. You're going to give her some instructions maybe on where she goes or who she calls, maybe when she'll have that done. So those are all factors that you may be providing, or all things you may be providing to the patient when they're in the office. And that is the end of our lecture. Thank you.